Right, well, can I just say first of all, it's an absolute delight to be invited to an LPC event. I think we, you know, in the LMC, Harry Yoxall, who's our medical secretary, who some of you may have come across, he's the chap who's always wheeled out to do these things. So a couple of weeks ago, he said to me, Nick, I'm going to do something for the LPC. Do you want to have a look at my slides? The first thing I noticed, he's got my name on it, which is a bit of a worry. So basically, these are basically his slides. It's his way of thinking about things, but it's I think he says everything that needs to be said really. So, oh, is it which one? The middle one. Where do I?
The one on the left, Nick.
I know pretty sound. The right. Oh, right. Okay, so right. So this is where we are. I mean, as you know, the NHS established in 1948, and a lot of it hasn't changed. When the NHS was set up, there was a lot of opposition from the medical profession, and one thing, they allowed sort of consultants to do a lot of their work, and they allowed GP practices to remain as independent contractors. Okay, so we're not employed, we're self-employed officially, with private businesses. So in Somerset we have 73 actually now, I think, private businesses. And that makes it very difficult for anybody to sort of contract with us. And I think the system really isn't really working. There are lots of things that have changed, and you know, this won't be news to many of you. We've got the demographic change, we've got the changes in our population. So people are living older, living longer. If you drive anywhere around Taunton particularly, you see all the building that's going on, and the population of Somerset is growing. But the demography also applies to us in practice. So we are getting older. I think there's it's quite a scary figure, the number of GPs in Somerset who are going to retire in the next 5 years. It's not scary for me, because I'm one of them. But it is quite scary, and so any modelling of what the healthcare system might look like in sort of 4 or 5 years' time is going to have to take account of that. Medical advances, you'll be aware too, the amount of medications that we have available now, the sort of procedures that are available, people are living very much longer. I'm a GP in North Petherton. I started there in practice in 1990. And I think when I started, I could count probably on the fingers of one hand the number of patients I looked after with dementia. And whereas now, you know, it's a very large burden of all the things that we do. Patient expectations, these, I'm afraid, are, you probably experience the same sort of thing. The media or the government will feed them all sorts of information. You can have this, you can have that. And patients expect things to happen, then they want X, Y, and Z. And there is this thing called the perfect fallacy. This is, as I say, these are Harry's slides. I looked at this and I said, what do you mean? And in fact, I'd have put the inverted comma, the second one after the perfect. And it's the idea that everything can be just perfect. You know, people don't get side effects from medications. Things are always curable. Whereas you and I, we all know that SH1T happens. Okay, people become ill. And then there's the denial of death. This idea that actually, yeah, people can just carry on living forever and ever and ever. Consumerism, 7-day services is a buzzword at the moment, and I think after Brexit, many of us felt, well, there was a lot of stuff on the media that Jeremy Hunt was going to go, and with it, the 7-day service mantra. And lo and behold, he got back into his job. We're not sure quite how that happened. But he still continued to say that we had 7-day services, whereas we feel we're really struggling to provide 5-day services at the moment. And then we particularly have the burden of regulation and inspection. I'm sure you do as well. But we have the delights of CQC now, and we have real problems in the way that some of the inspections are carried out. So, the proposed solution. Well, firstly, we're not expecting any help from the government. There are no white horses, there's no cavalry coming to help rescue us. Somebody mentioned earlier, I think it was Alistair mentioned about the Sustainability and Transformation Plan, which Marina might be going to mention later. But has anybody here heard about the STPs, or Sustainability and Transformation Plans? 1, 2, okay, 1. It's basically, in a nutshell, I think it's Simon Stevens saying to local health systems, CCGs haven't done it, you've now got to put your house in order. It's a 5-year plan, and one of the must-dos is to get the system into financial balance. Now, in Somerset, that's a huge ask over 5 years, whilst maintaining standards, meeting targets and building everything around us, what they call a sustainable primary care system. One of the problems we have all these internal barriers. And when a system's under strain, under pressure, very often people retreat into silo working. So, we says, well, no, I'm not doing that, I'm not contracted to do that. So we have these ridiculous situations. So for us, we have patients who see an optometrist, they've got a visual problem, the optometrist sends them to me saying, could I refer them on to an ophthalmologist? Now, the optometrist knows far more about eyes than I do, so why are you sending it to me and then on? Why can't you just send it straight there? And there's lots of examples of similar things that we think are absolutely bonkers. We've got to prioritise self-care and prevention. So in Somerset, our sustainability and transformation plan is going to be built around something called a health and well-being model. And that is, we've got to ask people to take more care of themselves, look after themselves. Prevention is a huge part of that. And although you can't expect people to look after themselves unless you're able to tell them where they can go to get information, so we're going to have lots of signposting, that sort of thing. Patients or service users should really see the person who can do the job. There's no point somebody coming to have blood taken and having an appointment with me if my nurse or a healthcare assistant could do it. People have got to be working up to their skill level, up to their pay grade. The theory of that, of course, it allows GPs or some of the specialist nurses to concentrate their effort on the neediest patients. We're hearing earlier, we're getting many more complex patients with multiple morbidities. That makes sense, but there's a large bit of me that thinks, actually, I really quite like looking after an antenatal clinic. I like looking after people with musculoskeletal problems. I like putting needles in knees and shoulders and things like that. I really don't want to spend all my time looking after very, very frail people with no community services. And that's a lot of what these very complex patients are. So what we mustn't do as a healthcare system is make the job for the people who are looking after these people so unpleasant that we all retire even earlier than we would do otherwise. So, anyway, some interesting side effects of the discussions that we've been having. We might hear later about some of these integrated care organisations that are emerging. So we're sort of reinventing ourselves a little bit. So there's been some integration happening between some of the practices and some of the large foundation trusts. And these units or accountable care organisations are going to be big enough to actually make decisions about who they treat, how they treat people. Hopefully there is this false sort of commissioner-provider split that has become quite difficult in the last few years. Privatisation of NHS services, there are little things that are being nibbled away. If you've got an accountable care organisation that looks after the care throughout, hopefully that will be less necessary. So, again, Harry's slides, constraints. Corporate primary care providers left outside the tent. He's really talking about large dental providers, large optical providers. We always have this thing that you can't actually redesign this healthcare system while the race is going. Now, we don't stop. Every Monday morning, I'll have people beating down the door. By 3 minutes past 8, all my appointments will have gone. We cannot turn off demand. And evidence for the best model is sketchy. I mentioned earlier this thing called the health and well-being model for healthcare. And a lot of that evidence has come from abroad, where the healthcare system they've got is different, the cultures are different. So you have to say, well, what would work best in our part of the world? And what works best in Somerset might not necessarily work best in Bristol. When these sustainability and transformation plans first came out, they were looking at 44 footprints, they call them footprints, around the country. Somerset initially was lumped in with Bristol. And we said that's never going to work, because what works in the middle of St Paul's, you can't equate to Exmoor. And the culture of NHS providers is different. We now have this split. We have some of the commissioning now is done by the local authorities, and they look after the social care, which provides a huge amount of the sort of burden of our work are people who've suddenly lost their access to social care because their budgets are being slashed even more than healthcare providers' budgets. And so the lack of social care is causing big problems for us. And the other thing is that we're not desperately good at changing. As individual practices, because they're private businesses, as demands change, we're quite good at tinkering. So I'm quite good at saying, we've got too many people coming in on a Tuesday morning, we'll adjust our surgery times, whatever. But in terms of changing the system, because it's also difficult, we're not very good at that. And there are now some specialist managers around who are coming in to try and help with that. So what do we do to make our Monday mornings easier? What are the quick wins? What could we do? Where do we have an underused resource? And what does the future look like? So we know that there are opportunities out here. We've got the GP forward view that was published, which looks to develop the system. And there's going to be much more opportunity for joint working. There is a pilot to get community pharmacists working in GP practices. I think in Somerset at the moment, I think there aren't that many. I think there's three practices, I think. One of my colleagues who works in Wincanton is very enthusiastic about the way it's working there. So they've got a pharmacist who does a lot of the post-hospital reconciliations, does face-to-face work as well with patients, and looks after a lot of the medicines quibbles that we get. I was saying over the meal earlier, we get so much of our time now is spent trying to sort out, unavailability of medications, trying to make cost savings, and it just takes so much time. How do we broker the arrangement, and how do we extend it across the practices, and how does it fit in with the bigger picture? How does it apply to community pharmacy? This is over to you really, not me, but we suspect that there is a willingness out there for pharmacists to do far more in face-to-face contact with patients. And we recognise that, and we would really welcome that. Community pharmacy is one of the three legs of medicines management. I think what Harry meant by this is that the patient comes in to see us, we prescribe, and then you guys dispense. And we're aware that there is talk of centralised dispensing. I'm not sure how you feel about that, but I suspect that potentially would release quite a bit of your time. And do you think it would be better working in a pharmacy or more closely in practice? My own personal view is it would be lovely to have people in our buildings with us. We know that we've lost all our community nurses in practice, and it's absolutely disastrous because although theoretically they're on the end of an email or on the end of a telephone, there's nothing like that coffee room conversation. Just have a chat. We learn so much from each other, and I certainly in my own practice in North Petherton, we've always had excellent relationships with our pharmacists. We had a bit of a rocky spell when it changed hands, and we really noticed the difference, and the patients noticed the difference. But now we've got very good relationships again. And should pharmacists reclaim professional autonomy by portfolio working? Again, that's not for me to answer. So what should we do? Well, I think evenings like this are fantastic because it's been really interesting for me to kind of learn what are your sort of thought, what's in your minds as to where we go next. CEPN stands for Community Education Provider Network, which is that something you're familiar with? No, okay, it's an organisation that's hosted across the southwest. I think we host it in the local medical committee actually. But it's basically providing education for nurses and other associated specialities. Because we recognise that if we're going to ask people to become, do more clinical work, you need to understand, when something's significant. We had, I've got a little bugbear of my own of NHS health checks. I don't know if you really enjoy doing them, but I piloted them in Somerset, and our concern was these were largely going to be for the worried well. And I still feel that's largely the case. But it's a question of when an observation is significant. For instance, I got somebody sent to me because their pulse was 50. When he was an athlete, he was really fit. But I think somebody had said, well, it's outside the normal parameters. So it's a question of training and getting used to, what is relevant. We should be concentrating on clinical services and the patients rather than the contractual difficulties. You know, if we design a service, surely we can sort contracts out to fit around that. And that's the other thing, slightly tongue-in-cheek, flu. Marina's laughing, yeah, good. You know, these are little things that then, when they come up, you know, they're little flashpoints, but they cause such a problem. And we should be working together to make sure people get their flu jabs, not sort of squabbling about how it happens. Anyway, that's all I've got to say.